Now we will move on to our Symposium 4, Looking into Future, the Digital Transformation in Healthcare. I would call upon the chairpersons, Dr. S. Ahilan and Dr. M.H.M. Ashraf, sir.
Good evening to all, and I think Myrodhan did a bit of a awake of the people, and hopefully I think our team will keep the audience awake. So we'll try to keep you all awake. I think this is actually been named as a appetite capsule, but probably all had a tea and good lunch. So I think it's not the appetite. Okay, in the symposium we have 5 people. So I'm just taking around 8 minutes just to give the sort of key trends in the digital transformation in the health care. Okay, now let's say that the areas that are picking up or trending up, like on the left first corner is the energy production. So it's both in the industrial and also in the medical field. So if you think of that, what has made the sort of a people to move into more digital? Like one thing is the generation of energy, how much generally we generate. The second thing is the storage of the energy. For example, let's say as a surgeon, if I wanted to use the headlamp, so I need the headlamp that remains around 10 hours functioning. To supply that, I need a battery, which works for long time, so that the durability. And also the size of the battery or size of the energy source. Now, most of the phones or most of the other devices, they want to make it large because of the size of the battery. And also the weight of this thing. Now we have moved into the polymerized batteries from the lithium, cadmium, sort of metal-based batteries. So in our digital transformation or in our field, I think I have to quickly finish, only 8 minutes. So that is helpful to reduce the, for this benefit. The next is the semiconductive chips, which we call microchips. So these semiconductive chips are useful again to reduce the size of the equipment. Also easy to sort of repair or like track the fault. Because just think if you have all our digital devices are connected by like a domestic wiring, so what would be the size of the device? So something to think on that line. The second thing is the global positioning apps, or the global positioning softwares, like what we are using in the maps and all that. Same thing that we are using in the navigation surgeries. So get the CT, get the MRI, register it, and then from the registration, we can go into the navigation surgery. Then every millimeter, especially in the craniofacial surgeries, that is very useful because every millimeter of a tissue you are removing additionally, you have the implication. Okay, the next is kind of these elevators. Now in the industrial world, if you see the elevators made the things easy. For example, say like in a very crowded city, so the ancient cities like if you go to Turkey and all that, there are layers of tracks. Like you have to go 100 feet down the railway tunnel. Or sometimes you have to go like in the Dubai and all that. You have to go 100 feet up to get the overflight. So where the escalators and the lifts are useful. Whereas the same thing in our practice, say if I say surgical practice, I would say like robotic surgery or robotic assisted surgery, where you can have the 10-arm robots or 5-arm robots, and each finger you can move the arm. So each arm will have the 5 fingers. So it amplifies the working force Whereas, in our routine practice, we know the pain and strains of the SHOs who retracts for hours and hours on the abdominal wall or even some other area. So again, a kind of a transformation we need. And the other is a genomic project. So it has helped us enormously in detecting diseases and sort of curing diseases. The third thing is the smartphones, right? So again, the smartphones, we know the use of utilization of smartphones and smart devices. In the middle, we have the lasers. Laser in the sense I am talking about the infrared rays and the blue rays, right? And some other nanometer rays. Now, for example, now some of the things in the medical practice we thought that we can't do is now we are doing. And some of the things that will give the complications now we are doing, like, less application in the hair removal, less application in the hemangiomas. So the laser has gone far, like, starting from the diode laser, carbon dioxide laser, and the BMA, ND, Q-switch lasers. Has developed a lot. The other thing in the development is the auto driving, like a Tesla cars. So the driving is the most conscious, and you need a lot of intelligence to do the driving. Whereas the Tesla system is coming into the high, it's like mostly the artificial intelligence. Okay, so in the health system, it is basically the popular areas are telemedicine and the artificial intelligence and kind of a blockchain electronic health records. I think probably our forthcoming speakers will talk on those. And the purpose is streamlining the physical work, optimizing the system, improving patient outcomes, reducing human errors. What people are thinking is if you give the robot to make an incision, it will be a real incision, whereas when the human makes, if you see under the microscope, it's like a wavy incision because we have the mild tremors. So it's coming up in the cardiothoracic surgery, especially in the CABG and all that. Okay, so the important areas in the medical and in the health, digital health transformation, like, all these are coming. Like so patient on-demand healthcare, right? I think probably Ms. Nawada will talk about on that. And also the importance of big data in healthcare, because the data processing, data collection, processing is the big area, and it's a big business as well. But at the same time, rather than seeing it as a negative side, there's a positive side. For example, say, I did a study on the surface of the circumference of the skull, and the anteroposterior and the sort of a dimension of the skull. Then a company came forward to collect the data. So the particular company is making helmets. So same thing like that. When you get the Bluetooth earphone, the Bluetooth earphone made in the States or in the UK may not be suitable for us because you should know the correct fit of your ear. So if you have the data of the ear normality, then people can make it very good fit. So something like that to think. Okay, then the growth of the wearables. So what I am talking about, like, the wearables that are detecting our diseases. Say somebody is a epileptic patient who will be detected by the device that he is going to get an attack. Then that will be easy. If something can detect if somebody is going to get the heart attack, so that will be the future, like a self-wearable devices. And so that leads to predictive health care and also the wonders of artificial intelligence I said before. All right. Now this one, like some of the data, like if you think like 52% of the all web browsing in the world occurs on mobile devices, right? And also 2.7 billion people worldwide own smartphones. And the 77% of the customers are going online to book medical appointments. So this is the world data, world digital data. So we have to convert, or we have to see where the Sri Lanka is. I will talk a little bit on the behind about the Sri Lanka. So this is the data, right? So the artificial intelligence, so that the world is moving, right? So let's say the situation in Sri Lanka. We have 21.46 million people in January 2021. And this is the 18.8% of the people in the urban areas and 81 in the rural areas. If you see the mobile connections, 30.41 million, whereas the population is only just 20 million, right? And the growth is almost like a 2.1%. And again, the total population, the mobile usage, 141% of the total population. So probably people are using more 2 devices. Right, and if you take a social media, right, and so 7.9 million people are involved, using the social media in Sri Lanka. And the growth is around almost 23%. So 36.8% of the total population is using social media in Sri Lanka by January 2021. So this is up to our next speakers to take the health transformation in Sri Lanka and in our system. Probably they will talk on that. Thank you very much. Next speaker is Ms. Nawoda. Ms. Nawoda, join. Hello.
Hi, Doctor. Very good evening to all of you.
Ms. Nawoda is Head of Growth, Digital Health Private Limited. She obtained BSc in Business Management, Project Management Specialist in First Class, MSc Special Strategic Marketing, and he is the founder member of something called Doc 1999. So she is the founder member, and probably he is having a lot of experience on the patient on-demand healthcare. Hope Dr. Nawoda, Ms. Nawoda, you will keep our audience awake. Nawoda, welcome.
Thank you, Doctor. Let me share my screen to all of you. Please let me know when it's visible. Hope it's visible to all of you, and all of you all can hear me. I'm audible enough?
Yes, Nawoda, yes.
Yes. So very good evening again to all of you all. Thank you very much for giving us this opportunity. So as Doctor introduced me earlier, so I'm Nawoda, representing Digital Health Doc 990, which is a subsidiary company of Dialog Asiata PLC. So I would like to commence the session on the topic that we were given to speak about, patient on-demand healthcare, which is actually the growing acceptance of the technology in the healthcare industry. At the same time, the millennial transformation of healthcare professionals and the connectivity between the doctor, patient, and the healthcare institutions in the future and during the current context of time also. So I think because I am addressing to an audience full of medical professionals, doctors, I think I would relate my personal experience as a patient. So assuming that I am not feeling well, or else I need doctor assistance, especially this particular incident occurred during the pandemic, where all of us as patients were helpless to get the medical expertise. If I am to go to a doctor, if I am to go to a hospital, the things that I would think twice, or else we would think twice as patients, would be first thing would be the travel restrictions, because there were a lot of border restrictions imposed where we cannot travel between one province to another. And then again, long hours drive. And then even if we take the decision of traveling to the hospital, which we were not asked to during certain times, then again, we think twice, am I exposing to the risk, which will again alert on the safety of myself and my family members. And then again, assuming that patients who've been exposed outside and then coming to the hospital to meet their doctor, again, do I have to wait in a queue? Assume that I do all that, we do all that as patients going through this. And then again, if I've been prescribed medicine, obviously, when we meet a doctor, we get prescribed medicine. So can I order medicine online and can I get that delivered to my doorstep? What about the lab tests? If I'm prescribed to do any lab tests, is there any way that I can arrange a mobile service? Do I have to go to the hospital again? Is there a clinic nearby that I can go? So all these things are time consuming, costly, and especially during a pandemic like this are the things that as patients, all of us face. Then there will be a second thought that can I connect with my doctor over the phone? Can I make a phone call to my doctor? Though that thought is very easily coming to our mind, is it that easy? Can I just blink with a blink of an eye? Can I just make a phone call? Is it that easy? So when we kind of dig in through, we also got to know that are we aware that patients research prior meeting their healthcare requirements. So this is with the norm of the global trends that we've kind of come across, that 77% of patients use online reviews as their first step of finding a doctor. And then 80% of these consumers trust online reviews, same as they trust the personal recommendations, because the personal recommendations have been replicated by the online reviews because of the limited touch to meet person one-on-one. And from there, they don't even limit themselves just by reading one online article, maybe a review, maybe a recommendation. On average, people read about 4 to 5 reviews before forming an opinion. Is it true? So we looked at few statistics which are available in the market, which will relate to global trends. At the same time, where it will relate to the Asia Pacific region's growing value of digital health trends, and the Sri Lankan market, because we will have to compare when it comes to localizing the content. So from the statistics that we have got, we have identified that from the total population, 1.8% growth that we can see year on year global. And when it comes to the Sri Lankan market, Sri Lankan context, the unique mobile phone users have increased by 7.5% every year. So there's a very positive variance, and that will cascade to the internet users. Then again, drill down to the active social media users. In global, it is 13.2%. And in Sri Lanka, it's 8.3%. So I think the statistics will resonate the facts that we are trying to speak about. So when we relate this digital presence in the market to a more localized context, people like to have easy access through modes like USSD, and then M-healthcare services, mobile healthcare services like call center assistance, and people who are a bit tech savvy would like to get themselves self-assisted. So through web-based, app-based, and also they also prefer these hybrid models to digitize the healthcare requirements that they have. So looking out a bit, we've also found out through a research study, again on a similar symposium done by WHO, there are 8 principles that they have identified which governs the patient-centered care, which will be drilled down, more cascaded to the patient on-demand healthcare, which are the access to care. Again, why I have highlighted the fact is that fast access to reliable health advice, not just advice from a person, but from medical professionals, a reliable healthcare advice. And then respect for patients' preference, personalization is the fact. And then coordination and integration for care, physical comfort that the patients are expecting, and then again, emotional support. Whereas it will again be supported through the involvement of family and friends, and then information and education, continuity and transition. So then I think we have reached to the main topic of what is patient on-demand healthcare. So the human-centric healthcare, we have analyzed and kind of compiled the steps or the cycle which interconnects with one another, whereas how patients are more focused on getting this shared decision making, on moving with doctors, or medical professionals with shared decision making, not just limiting themselves to do what they asked to do, but they also do research by themselves, refer to previous articles. So I think because we come from and we represent an online presence, a digital medium platform, we have seen a lot of people are driving towards content. Can I have these questions sorted out from my doctor? Can you reach out my concerns to the doctor? So they research. And then likewise, from different blog articles, from different other sources, patients, they gather information and then they analyze one on one. And then because now we have combined the social media presence or else the digital platforms, we have seen trends where people share and review. Even I think we do that. We simply take a picture of the details what we have, and we share it through WhatsApp, Viber, and so many other platforms that are available. Why do we do that? Sometimes when we share a picture, what do we expect? We expect a comment, or else we expect a feedback from the other person or the community that we share. So that is where we are coming to the fact of relating. So they want to relate it to the other person's idea, and then the personal experience that they have gone through, and then afterwards fulfill. So this is the whole cycle that revolves around, resonates the patient on demand healthcare, mainly the requirements. And then looking into the problem statement, what is the need to patient beyond demanding the healthcare? Why do they want a more patient-centric, human-centric, more collaborative, shared decision-making approach? Is there a particular reason? So if we take the traditional or else the normal healthcare journey, what we've seen is that patients have to go to the hospital and then they have to meet the doctor, wait in the queue, go to the lab, pharmacy, and then if it's an admission, it's a different setup. So when we face with the coronavirus, the unfortunate pandemic that all of us had to go through, all these traditional behavior, all these previous behaviors seem to be not very convenient to the patients. So then again, they wanted to know, and at the same time, from the regulatories, from the government, everyone restricted the physical interaction. But there are certain instances, there are so many instances where we need physical interaction, but for the minor things which are not complex, is there any way of us getting this support from our doctors through other mediums? So that is where this whole patient on demand solution overview, the transformational journey is addressing towards. So if we take a channeling, if I am sick, the same use case, the test case that I took before. Can I channel online? So if I'm channeling online, I need to fill the COVID-19 verification. So then again, I really, if it is an example of myself, I don't prefer to again stay in a queue and fill it. If I get that through an SMS or a web link, just to submit my answers, and then on my way to the hospital to show it to the front counter or to the security person, that is the most preferred way when it comes to an angle of a patient. If not, if it is a symptom which is very minor, let's say for a headache or something, and because of the restrictions imposed by the government themselves not to go to the hospitals unless otherwise it's necessary and critical, people tend to think, can I? But then again, we need to have the medication. Then again, we need to connect with the doctors. Can I talk to my doctor over the phone? That could be an audio call, video call, or a chat message. So when we connect to the doctor through an audio call or a video call, we prefer as patients to get prescriptions because that is the end point of getting the medication sorted out. And then again, when we go to the hospital, we take our files so that our doctor will assess the previous records and tell, okay, now you're maintaining your health condition very well. You need to continue or you don't need to continue. So that advice also we need to get. And then the images, if we have come up, if we have gone through an injury also. And then the pharmacy, the mobile ads, everything. Can we get all the other services, value-added services, one-stop shop, where when we connect to our doctor over a video call, over an audio call, or else a chat message, when we get the prescription, the ability of getting the medicine delivered to the doorstep, island-wide. It has to be across. I think I am representing Western Province today at this forum, where I have connected with all of you all through an online medium. So, but y'all are at a different area. So this whole connectivity part can be also bridging when it comes to have a seamless patient and a doctor user journey. And then if they want to have a lab test, the test that can be done mobile, better to prescribe and get that online, and then get the reports online also. And also on another note, if there are nursing facilities and then other doorstep emergency care facilities, again through one call, people would like to connect. At the same time, not forgetting the masses where they do not have access to internet, or else where they do not have the access to access, or where they do not have smartphones. We also have come up with facilities where they can call the solution providers through mobile healthcare solutions that is done through feature phones using USSDs, a simple common number, unique number to a call center, so that through there, the services, every service which can be supported will definitely be delivered in order to cater the patient on-demand healthcare services, having a very well synchronization and advice from the doctors when we can give it out to the patients. And then also coming into a situation where now all these digital solutions will not be substitutes or alternatives to healthcare services. There are instances and there are so many concerns where we cannot sort out over a phone call. We have to go to the hospital. Yet again, the solutions that we have come up would be the ongoing number, the next available number, where doctors can assist the nurse assistant who will be outside the channeling room to update their nurse tab, so that it will replicate as a text message to the patient while giving an online accessible real-time link where patients can view the status of their appointment. Has my doctor gone for a surgery, a theater? Have they gone to the theater, or else is there any is she taking reports? What would be the next number? So these things can be looked and analyzed, or else think through before. And if we've what I think as patients, what we do is we go to the hospital a bit advanced, thinking that we might come across different other concerns on our way, or else we might have to get certain reports from the hospital likewise. So then again, without exposing, we can stay in a rest area, or else if patients have gone through a vehicle, come in a vehicle, they can stay in the vehicle, and then they can check the number and then walk into the hospital at the specified designated time. This will definitely support the healthcare professionals, the doctors also, in order to reduce the queue, and also in order to have a very seamless consultation ongoing. So this could be applied ongoing solutions like ongoing number, online payment platforms. So these solutions can be applied for both primary care and also secondary care services. And then coming into another very important area where I think us as a private institution, we've been continuously questioned throughout these years whether all these services attributed to a very niche segment where they are credit worthy enough to access these services by paying per service.
Excuse me,
They
Nawada.
okay.
Nawada?
Yes, please.
Sorry
Yes,
for the
please.
inconvenience. I think you have another 1 minute, 1 or 2 minutes time.
Sure. Thank you, doctor. Thank you very much.
Thank
So
you,
I'll just,
Nawada. Yeah.
yes, no worries. I'll just quickly wrap. So these services we have also extended to the government healthcare pillar with the corporate social responsibility CSR initiatives for on-demand healthcare. So introducing helplines like 1390, which is a toll-free solution, where providing COVID care support in collaboration with doctors, where patients can get home quarantined. At the same time, 1390 and Doc 990, the online solution, which is already deployed at Laidridge Way Hospital, where patients can simply call 1390. They can get their clinic selected and then make the appointment in the system. And then they will get the SMS notification on the appointment details and go there on time. So all these services will be rolled out to the government healthcare institutions. Other hospitals also, if we take in the pipeline, National Hospital, Castle Street, Eye Hospital, Karapitiya, likewise, we have a lot of hospitals in the pipeline to deploy the same service, which will definitely give access to the patients island-wide, nationwide. And also, lastly, my last slide, how we can connect the ecosystem, the roadmap, with the patient on-demand healthcare services. So we have come up with the trifactor, 3 elements of patient on-demand healthcare, such as service design, where we can create solutions for both primary and secondary healthcare sectors, and then with a more personalized touch. And then technology activation through app and other in-health solutions, and data intelligence, where we'll again be specifying on the EMRs, electronic medical records, chatbot services like that, where I even would go into an extent of using AI, artificial intelligence, for preventive care, where we can give health walls for patients access. They don't have to carry files to the hospitals anymore. Yet again, to connect to have a more connected relationship between the doctor and the patients, because without that connectivity, actually no point of introducing services. So that collaborative approach, more a digital approach, we say, physical and digital approach, because digital healthcare is by no means intend to replicate with technology. We really cannot do that, is what even we think as solution providers. But we can advance and quality. We can advance and provide quality of care, enabling convenient access through digital channels, and also strengthening the ongoing relationships between doctors, healthcare institutions, and patients. So I would like to end my session with the note that we highly appreciate, as patients, as all of us, we highly appreciate the unwavering commitments that the medical professionals render to the mankind, especially in a country like Sri Lanka. We highly felt that in an event where we've been affected with an unfortunate pandemic, where doctors were the only source of relief that we have. By seeing them, it kind of gives us a lot of relief. So thanking the unwavering commitment and highly appreciation from our end. So in future also, we would really like to create engagement with different, we can do seminars, webinars, different other forums, where we will connect the whole healthcare ecosystem, digital approach, physical plus digital approach, in order to cater the patient-centric, patient-on-demand healthcare requirements. So with that, I would end my note. Thank you very much again for this great opportunity given to digital health. Thank you.
Thank you, Nawada. I'm sure that you are under time pressure. I hope you will stay with us till the last moment, but I don't know, I'm not sure whether we can entertain questions, Nawada. Thank you again, Nawada.
Yes. Thank you, Doctor. Thank you all. Thank you very much.
Digital transformation in Sri Lanka, we are in very primitive state. If you consider teaching hospital Batiklo, we are in more primitive state, but in out of many departments, the laboratory is in the front field in digital transformation. We have already initiated laboratory information system. So Dr. S.I. Majita, consultant chemical pathologist, is going to present the medical laboratory information management system. She graduated from Kelaniya University and MD Chemical Pathology Colombo. She underwent overseas training at University of British Columbia, Canada, consultant chemical pathologist at Teaching Hospital Batticaloa, examiner at PGIM in chemical pathology, member of Board of Study in chemical pathology, PGIM, and technical assessor medical laboratory accreditation, Sri Lanka. Majita, over to you.
So good evening to everybody. So thank you very much, Dr. Sundaresan and team, for giving the opportunity. So this topic is vast, so I try to finish within the allocated time. The laboratory information system have evolved into complex applications to meet the specialized needs of the laboratories as integrated delivery system continue to emerge as a dominant model for healthcare delivery. The evolution of LIS has evolved to cater requirement of laboratories with complex application in all the areas of laboratory process. Start with paper-based system, going through the several phases and leading to a LIS system. So if you take a paper-based system, everything done manually, so the chance of error is high. So you can see these pictures. Everything entered manually, handwriting. So the next step is the direct printouts from the instrument. This came to the place after introduction of automated analyzers with the attached computers. So samples labeled by handwriting, the demographic data enters manually into the instrument computer. Results are printed out using the instrument computer software. So the data backups facilities is limited and the report format customization is minimum and need manual data recording for the future reference. So the unidirectional transfer of data. Here the two computers come into play. One is attached with the analyzer, other one is interfaced with the software. So when we get the sample, we assign a number to that sample and enter the demographic data to a second computer with the limited interfacing software according to that assigned number. The tests are requested by from the analyzer by the operator according to the request and assigned number. So the reports are generated in the analyzer and transferred to the second computer. That is a unidirectional. So here the report format is customizable and the data backup is available. So the bidirectional transfer of data, the same two computers, but the information also transferred to the analyzer and the results are back to the second analyzer. So all the informations in the barcode system, so analyzer can read the information encoded in the barcode and to do the analysis. Analyzer transfer back the completed results to the second computer. So you can get the printouts or you can send the report to the wards or wherever it is necessary. It's a user-friendly system, can keep the data backup for a retrieval and reports are customizable. It's an advanced system and functionality vary with the complexity of the interfacing software. So the laboratory information system, that is an advancement of the bidirectional data transfer. So sample labeling with the barcode, all processes from the sample acceptance collection to the delivery of the report can be incorporated in order to manage the laboratory efficiently and effectively. You can track the sample, calculating the turnaround time. You can get the alert results, validation, commenting, data mining, inventory management, QC management, reporting through SMS or email, all are possible here. Can be integrated to the hospital information system in order to improve the service generated by the laboratory. So what are the advantages we have? You can instant accessibility, reduce the manual work, improve the capacity and the productivity, improve the turnaround time, improve the service levels, and assure accurate and timely availability of information. So we can entertain all these advantages, but there are concerns about the implementation of LIS system. So in Sri Lanka, laboratories are with different stages. So you need to begin from one of the above stages. Different issues will be encountered with the new implementation depending on your starting stage. If we understand the problem clearly, can overcome the issues without affecting the workflow. So need to predict issues before implementing a system. So there are 3 components participating in the implementation: organization, human resource, and technology. So issue to be expected and troubleshooting. So what are the issues in the organizing the LIS system? The concern from the stakeholders are the interested parties and infrastructure facilities. So if you take the concern from the stakeholders, there is a concern about the sample registration system, report delivery system, which way we can deliver the report, electronic, paper-based, SMS or email. So availability, computers, printers, mobile phones, and etc. Availability of intranet and internet facilities, and the literacy level of the people, the computer literacy level. So how can we overcome? So do a survey among stakeholders, analyze the concern, and form a committee, discuss issues before implementing and before preparing the specification. So concern from the infrastructure facilities. This is needed. The spaces and the operation, the network, the spaces for the operation and the network is necessary. Solution, for the small lab, we can manage within the laboratory. If it's a big lab, we need IT room with a space for server. Networking should be designed according to the existing analyzer and for planning for the future expansion. The switches, we have to get the manageable and non-manageable switches to incorporate all the analyzers. Separate intranet needed or share with the hospital information system. You have to discuss with the IT department. The internet facilities common and shared. All these requirements should be facilitated by the hospital administration. So those are the issues regarding the organization. If you come to the human resource, you have to think about the lab people and the IT person. So from the lab people, you have to think about the computer literacy. This is very important to run the LIS system. So solution, you have to do a gap analysis by assessing the literacy level of the people. Train them to get the minimum required skill, assure them there is no big task to operate LIS. So IT personnel. So there's a problem thinking of who is the responsible person for the data entry operation. So train the existing staff for this purpose. Other one is a big issue is the attitude of staff for the change. Educate them regarding the advantage of the LIS rather than just implementing. Who will manage the hardware and the software? LIS provider usually online and sometime in the on-site come and train our people. And for the minor issues, they will train our MLTs and the IT people to overcome those problems. So the other one is a big task is a technology, is a hardware solution and software solution. So concern from the hardware, we have to have a compatible server with a backup system, adequate number of connecting computers, barcode printers, readers, printers and scanners, network and available network ports, and uninterrupted power supply and surge protectors. Solution with the server, you have to select the suitable server with the necessary speed, memory, and storage. Should connect to the internet line for the LIS people to troubleshoot. And data should be stored in a backup server from the HIS system, hospital information system. Better to have a separate server for the laboratory rather than sharing with the IT department. So adequate number of computers should be there for each and every analyzer. There should be a separate computer for the registration. So barcode printer should be communicate with the barcode printer without errors with the LIS system. If any special requirement need, we have to address that earlier. And continuous supply of quality of barcode labels that should be supplied by the hospital. If there's no barcode labels, we can't print a barcode. So we can't do the test. So that should be supplied without interruption. So network and network ports. So network of the laboratory should be able to connect all the analyzer with the server through the manageable or non-manageable switches. So need adequate number of network ports for the future expansion. So available network ports not enough. We have to think about the future. New analyzer will come. We have to incorporate all the things into the system. So this should be linked to the hospital information system in order to transfer reports and obtain data from the HIS. So uninterrupted power supply and surge protectors. Sudden interruption of power surge due to electrical disturbance, lightning will result in software crashes. So even this can lead to a mistransmission of data. Wrong data can go to the system. So need to be equipped with the surge protectors. So issues related to the software, this is the most important component of the LIS. The concerns are sample management, instrument integration, that is interfacing, data management, and quality control data handling. So sample management, we need to extract from the HIS. Once the patient come and registered in the hospital, when the lab report, the investigation come to us, when we put the PHN number or whatever it is, the data has to come. So then easy, quickly we gather everything and order the test. So otherwise, when the test repeated, so already done one patient and repeat tests are coming, when you enter the BHT, you can get all the data, which ward, what is the name of the patient, age and everything. So that's a quick process. We don't need to do anything manually. So interfacing the system. This is the most important part. LIS provider should be able to integrate with all the available system via international standards such as HL7. A feasibility study should be performed before accepting the tender by the supplier. Should be able to integrate with future analyzers. So this system should be able to integrate with the HIS as well. So data management. The complete set of data should be transferred. The partial we can't accept. When the alerts are come, there's a problem in the sample that should not send data or report. So it should be transferred. Otherwise has to give the alert to the user. So critical value should be alert the operator. Facility to calculate the data should be available. There is a EGFR calculation, albumin creatinine ratio, that should be there. Easy way to add reference range commands, etc. should be available. Password protection with the tracking facilities. Customized report formats. E-signature, emailing, SMS, sending PDF reports as end products. Generation, if you want a different format of report, and another category of report, that should be available. So quality control data, we can manage our QC data as a patient data. We can incorporate QC values and we can manage it, and we can make averages, that means moving averages with the facilities available with LIS. So with every software update, there is a risk of error generation. Service provider should provide a validation report at the installation and with the major updates to the system. System updates are allowed only after temporarily stopping the system in order to prevent mistransferring of data. So in order to incorporate all these functionality, specification to the LIS should be written after analyzing all the requirement of the laboratory. Later addition will cost you more. Even after installation of LIS, you will encounter numerous issues. Remember, even though this is a computer-based system, operation is a human, everything depends on the operator. Thank you.
Thank you, Dr. Majita, for your excellent presentation. The laboratory information system is very expensive one, but there are many advantages on that, because we are not considering the data. Each patient, every report is a data, but we are not utilizing. If you see the Australian health budget, 25% of the budget is expensed on the information system storing rather than the treatment. So you can do a lot of researches, and also there is an evidence. For example, if there is a laboratory information system, we know at what time the specimen came to the laboratory and at what time it has issued the report. So everything, nobody can change the report, so it will improve the quality of the treatment. So now I move into another important area, the radiology. So the radiology also, the digital transformation is very fast. So Dr. S. Dilakumar is going to speak on the picture archiving and communication system, or PEC system. Dr. S. Dilakumar graduated from University of Jaffna, MD in Radiology, Colombo, and he trained in Royal Perth Hospital, Western Australia, and he is a life member of Sri Lankan College of Radiologists Dr. Dilakumar, over to you.
I think it's going to take some time to install and run. If there is any questions in between, you can ask Ms. Navoda and you can accommodate because the time matters. Time factor is very limited. We don't see any questions in the chat box as well and the question and answer box as well.
Wherever already the existing network systems already connected to the wards, wherever the connection is there, we can send our reports to that connection and the people can visualize the report from the wards. The connection is not there. We have to arrange for that, and that is another network connection we have to make from the hospital.
Good evening, everybody. Thank you for Medical Association for giving an opportunity for me to present this, and for the Dr. Sundaresan. Thank you. Picture Achieving Communication System is called PACS. This is the most important element of digital transformation in radiology. So radiology is based on this in all other countries except Sri Lanka and only few countable number of countries. Now almost the paper form and film forms are disappearing from world because I will come to that later why. So what is picture achieving communication system? The pictures are achieved from various modality and it's stored in a well form, and it is whenever you want, it is retrieved and transferred to the relevant team at specific time. So the software we are using is called DICOM. Without this software, you cannot open any form of film. So most of the clinicians comes and say, our computer is not opening this CD because you don't have the digital imaging communication software. You can download this easily. It's free software is available, so you should take time to download this software before you comment about that. So what are the important things we need is, there are 4 major things. One is imaging modality. You should have a latest imaging modality to connect to the PACS. You can't use the oldest methods because those does not have a communication system, certain imaging modalities. And you should have a secure network. Those networks should not use for your normal internet purposes like other purpose, the cybercrime and their viruses can be loaded. Therefore, this should be a different network securely placed. And you should have a better workstation. Normal computers cannot be used as a workstation. It should be a little bit higher versions should be used. And a good storage facilities. Unfortunately, when I came to Batiklo, I realized we didn't have a workstation for our CT scanner. So it was down 8 years back, but it was not yet replaced. Hopefully, the new CT scanner has 3 workstations. Thanks for the donors. So what are the advantages of the PACS? This has eliminated the manual file process, storing facilities, which need big storing facilities. We gave it to the patient. There are no hard films comebacks because they fold the films, we cannot read it back. The environmental impact, yesterday they comment about environmental impact. These films has lot of environmental impact, so filmless and paperless is most important in future. The PACS are increasingly important for, as he said, to do analysis studies on retrospectively. Also, each patient, we are taking a lot of imaging for individuals to retrieve those things. PACS is most important. And it can store various form of images, 3D to 2D. So that will be stored at the achiever for your retrieval in later stage. Also, you can reduce the number of duplicate images. Now, if you say CT non-contrast are done before doing CT contrast in certain patients, if that is not relevant, you can always erase. Also, there are images when the patient is moving. It is distorted images that also you can erase and store the relevant images to the achiever. And all the images can be chronologically traced back at whenever you need. So when you are comparing images, there are two screens are available with the PACS. So always you can compare the images, previous cancer patient, how the radiotherapy treatment, how the lymph node has reduced or not in the same setting. So further, PACS provide remote access. You can report from home or certain countries. Australia, I was working in a center. I was covering up 1,500 kilometer radius. So I never see a clinician. Once, if they come for conference, we used to see them, but daily we communicate with them. That way, it is easier managing with fewer consultants, they can manage. Now, we have distributed so many consultants, we are not utilizing their effort. If you see, General Hospital Ampara has 2 consultant radiologists, Kalmune North has 2 consultant radiologists, but the number of workload is heavy in teaching hospital particular, so all of them can be shared if the PACS system is there. Also, hospital can benefit. They have the number of patients done, how many has been done, every record will be with them. And no cheating can be done. Once you're done, you cannot erase the films from the PACS. 3 persons has to sign to erase the PACS. So who can use the PACS? So now it's a trend. Almost all the consultants want the 3D image and other images. So oncologists, cardiologists, orthopedic surgeon, whoever, they want to use the PACS. So what is this image? Now, say one image has been already done. If you have a PACS system, you can adjust the PACS to the limit, you will be able to see. This is technical error. They are overexposed the film. You won't be able to see anything, but the contrast adjustment can be done in the PACS. So not only X-ray, anything you can change and view more images. So type of images can be included in the PACS are, if you see CT scan, ultrasound scan, PET scan, MRI, fluoroscopy, digital extraction, all can be combined. For overview, I want to show the workstation and the PACS will be appearing same. The PACS at Australia and Kalmune North is almost similar, if you can see. Unfortunately, still teaching hospital, we don't have a workstation. So hope very few weeks, we are hoping to have the 3 workstation installed with the new machine. This is the PACS system. Now I am going to start. Although we have the PACS system, these radiological images should be combined with the hospital imaging information system. Otherwise, you can't retrieve all these images whenever necessary. If the patient comes to clinic, clinician has to review. So how we can combine PACS and the radiological information system? Before that, we have to know the few terminology. RIS, they call RIS, is a radiology information system. HIS is a hospital information system. Majida mentioned few of it. Then electronic health record is EHR, and DICOM is a digital imaging communication software. So these should be combined in this way. You have to combine this with the PACS to get the relevant images to the workstation. So if you see, the RIS is Radiology Information System, HIS, HIS is Hospital Information System, or Electronic Media Information System can be combined with PACS to coordinate, but PACS is separately stored in the images. So for all these, this DICOM software is most important for us. So what is the use of these PACS and the DICOM images is, you can transmit to another area or distant places. You can immediately transfer, even to the wards you can be transferring. So we talked about environmental implication. This is Batticaloa Beach in the early morning. So we are using this without knowing how much environmental impact you all are causing with these hard copies. These are silver material, right? So when you were using previously, the old generation, you know, you were hand washing these X-rays. These are containing few tanks. All the chemicals are drained into our normal drainage. This has, these few X-rays has this much of silver metal can be taken. Those days, I remember people used to come and take these X-rays without our knowledge to get this silver, because silver is expensive, this part of silver. So, as we have advantage, there are disadvantage. These packs are expensive. So, to overcome this, it will take 5 years. So, initial expense is very high. Next is the change of workflow could be frightened for conservative radiology and physician. If you are up with the newer generation, you can hope up. And the most of the staff will need introduction and additional training to work with the PACS. Total system failure is a disaster, because you are already changed into PACS system, you don't have any conventional method, you will be in trouble. So you should have a small area for conventional method in case of emergency. Maintenance unit should be within the hospital, and confidentiality should be maintained. As I have time, I will go into the detail of that. So the one is expensive. The fallback position, which is called, is a disaster. Once a hospital has become filmless because of the means of infrastructure generated and distributed in according to that, you are finding it difficult to go back to the old system. So in nightmare like a cyclone or a disaster, if all the things are broken, you cannot go back to conventional method. So always you should have a spare conventional method in case of emergency. Still, the hospital I worked, Royal Perth Hospital I worked, during my time, they had a disaster only once. During my 2-year service, they have a backup, so they should be able to manage it. So always, when they have PACS, they should have a backup system. Other thing is the imaging equipment has to be upgraded. I included Batticaloa in 2017 in the ministry list for PACS system, but unfortunately, they have put the wiring only, they haven't got the equipment. What will happen if you put the wiring? They have done a Cat5 wire. Now the system has gone to Cat6, Cat upwards. So when the new equipments come, the Cat wire will not hope up the capacity it's going to transmit. So when you are installing PACS, there are new versions are there. So when you install, it should be installed with the wiring at that time. And the PACS vendor should have a communication with our team, and they should be available with us. And if they are going to do any correction, they should do it during the public holiday or Sundays to overcome PACS disaster. Medical staff welfare of PACS system, especially house officers, they have to fill the form correctly, otherwise PACS will reject however much you ask for a. If you don't fill the serum creatinine, it will not allow you to go ahead with the CT scan. So you have to have all the things correctly. I come across ETU requests without even the history is written. So however much the electronic system improve, history is important. History you should write. It should be design the protocol according to your history. If RTA, we decide the history according to that. Please write the history. Whatever PACS, whatever digital system come, there are all clinicians, they cannot forget about history. History is important. And some PACS are very user-friendly, some are not user-friendly, so getting used to that is important. In a summary, PACS is most important with developing world. As electronic things are happening, we are out of date of films. Eliminate the need of manual files and store. Our clerks are still scared in the ministry to eliminate the file. Still, they are pending in the file system. And it is very speedy communication before the patient comes back to your ward. You will know that CT has been done at this time. Only thing is PACS is expensive. It reduces the environmental impact. PACS provide remote access. Even night I can report from home, so you don't need to worry. Whenever it's come, I will be before you come, I will be reported the film. Thank you very much. This is Batticlow, my backyard. Thank you.
Thank you so much, Dr. Tilakumar, for an excellent presentation.
Next speaker is Dr. M.Y.M. Ajwad. Ajwad obtained MBBS in University of Colombo and the MSc in Medical Informatics. He has worked as a lecturer in Saudi Arabia, so he's having an overseas exposure, and also reading health informatics. Hope Dr. Ajwad, you have joined us. He is coming through the, okay, Ajwad,
Yes.
welcome. Yeah.
Thank you so much, and thanks for inviting me as a resource person in this symposium. And I think I have, I think you must be having a lot of questions from me, and as I am now moved into my career level, so maybe I would be able to give some promises. Anyway, I'm going to share today, I'm going to talk about the national EHR. So let me share my screen. I think all of you can hear me and see my slides. Is it audible, and can you see the slides?
Yes, Ajwad, you are clear, and the slides can be seen.
Yes. Okay. So today, and I would like to welcome you all, like a very good evening. And I think you are running out of time, and I'm not going to take much of the time, but I need to tell some importance about this health informatics by giving some insight. So with that, my topic today is to talk about the National Electronic Health Record, in the title of Every Citizen Has a Record in the Cloud. Yes. So there was so many confusion with this terminology, EMR, PHR, EHR. And then I just wanted to be adhering to certain type of terminology. So first, what is this electronic medical record? It's a computer-based information system which collect, store, and display the patient encounter information. And EMRs are similar to the digital versions of the paper-based medical records. And these contain the personal and clinical information about patients' clinical encounters, at single practice or healthcare institution. So it is, you should note this, EMR means the services are provided. And EMRs shall have basic components, patient registration module, admission, discharge, transfer module. That's what we have it at the Beticlo at the moment, and clinical modules for OPD clinics and wards. We are, I would like to say that we have some upgraded versions of the information system nowadays, and the laboratory information module, which is the RIS PACS, because RIS communicate with the PACS that already Dr. Tilak talked about the PACS, which the RIS communicate and retrieve the images, and radiology, the pharmacy module, and the laboratory information module. Finally, in some relevant instances, financial modules. So these are the basic components. In addition to that, the EMR should have a decision support system. So that can complete that EMR picture. So what is then the PHR? The PHR is a personal health record, which is an electronic application through which a patient can maintain and manage their health information. Not only their information, they can manage the people who are authorized for, like their children, siblings, or the parents in a private, secure, and confidential environment. What is then the electronic health record? So electronic health record are electronically managed repositories of individuals' personal data from birth to death. So it is kind of a repository, longitudinal records, which contains all the encounters of individuals. So today I'm going to talk about this EHR, which is planned to be or going to be implemented at national level. And then the PHN, of course, many of you know that this is the BHT, where you can see that PHN is printed on the top. You may be not aware what is included in that. It contains three parts: the point of issue ID, and the next font alphanumeric ID, and the random alphanumeric 6-digit character, and final digit, which is a computer check. So you might be knowing that the THB is issued with a series of point of issue IDs, and we are utilizing at the moment 3 of them. So now let's have a look at the Sri Lankan digital landscape, especially focusing the services and application in state sector. I think Ms. Navoda talked about the patient level on the private sector. I am going to discuss on the state sector. We can categorize them into the state sector information system, the preventive sector information system, curative health information system. In addition to that, we can see the registries and data services. Currently, we have some of these you can see the listed out, and they are the implementation at the national level. This electronic reproductive health management information system, which is implemented by the FHB, the Family Health Bureau, and recent implementations of COVID-19 surveillance. This is a kind of a surveillance system, which based on the general public good, the DHIS2 and the immunization tracker, and these again individual data captured, and some of the systems they process and get the aggregate data, and the SVC, the Smart Vaccination Certificate, which nowadays you can get it through online portal. You can just send your request and you will get that. And the NCHIS, which is the another laboratory-based COVID-19 surveillance information system from the Ministry of Health. What about the curative sector? There in the curative sector, there are several implementations. Both like on-site and off-site. Mainly in, can you all hear me now? Can you hear me?
Yes, yes, Ajay. Yeah, yes,
Yeah,
Dr. Ajay. Yeah.
yeah. I'm sorry for the disturbance, of course. The main information systems that are implemented, I'll invite the HHIMS, which are mostly implemented in the district general hospital and base hospital levels, and HIMS, which are implemented in more than nine teaching hospitals. And the registry and data services, all of you are aware the electronic indoor morbidity and mortality data that again we are also sending from particular hospital through these the HIMS. And the recent implementation of National Cancer Registry. So basically, according to my previous the terminology definitions, these two information systems or any other that are going to come up are considered as EMRs, or the electronic medical record system. So what are the issues in these different kind of information system? Data duplication and fragmentation of these health information system, and the need for a continuation of care, the live data of the patients, and unavailability of these clinical data for the administrators. So the objective of the National Electronic Health Record include to facilitate the continuation of care. And as we earlier heard about the patient level on-demand services can be empowered through enhancing the patient empowerment and the meaningful use of the clinical data for administrative decision-making and improve health information privacy. Similar implementation globally, National EHR Singapore, Patient Portal Estonia, and My Health Record, and even NHS in different trusts they have. And what are we going to achieve? Improve treatment with prompt and accurate information exchange, improved efficiency of services providers from automated workflows, and improved patient safety and reduce potential for adverse events with the records that are available, improved health information privacy and confidentiality, and so on. So this, I'm going to discuss in this slide about the high-level architecture that is of the National Electronic Health Record. So these, the high-level architecture contains the three layers. The first layer, that's I have already discussed, the information systems and the registries. And then the second layer comes the National EHR. This National EHR is basically a repository. There won't be any direct logins to the National EHR. You should access, or you must access through approved curative health sector information system like HIMS or HHIMS. There won't be any direct access to the NEHR, but it will hold the longitudinal health records of individual patients. So these will be two-way transfer, and the latest data exchanging standards will be followed, the HL7 FHIR. And we don't forget the patients, and we have to provide them the national portal, a national PHR portal, where the patient can also access the national EHR, but they can maintain their own data, which are developed through the mobile apps they are holding on, but those should be verified, and that can be get through the national EHR. If the general practitioner or any others, they don't have authorized applications to access the NEHR, that access can be given by the patient. So these patients are empowered. So the workflow of this national EHR will be the patient can go and register by themselves, self-registration, and they once they positively identify through a national identification system, there and then two-factor authentication, the account will be activated. And they can also go to the registration desk in any health institutions where the systems are authorized, and they will be verified with positive ID, and they will be issued the PHN. the primary PHN. Why I'm saying primary, I will talk about the secondary or then. So through the hospital encounter, the patient's information will be transferred through the hospital information system or the health information systems to the national EHR to be saved in longitudinal health record with the verified ID. So this can again retrieved by the any other information system independence of the geological location. So again, these aggregated data can be used in the national database, and also patients will be empowered, as I told you earlier. And what if the patients are not positively identified, again, they can get the services and they will be issued a non-verified PHN. And their data also will be saved into the NEHR repository, but they are marked as non-verified health data. And this is, we are doing it because we want to have it for the national statistic purpose. So in the patient empowerment, the patient have the authority to opt out to send their data to the national EHR. By default, they are opt-in to the system, but they can have opt-out facility as well. In some cases, the patients wanted to have another PHN. So for example, if they wanted to take treatment for their like STD care, then they can have a secondary PHN, and that data will be also in the NEHR, but that won't be accessible by the national information system. So there are certain 9 guiding principles on implementing this NEHR, the ownership of the data to the patients. So that's again the patient empowerment, and the system will be owned by the Ministry of Health, and the institutions which are connected will be responsible for quality of the shared data. So that's again, and the second principle is healthcare encounters. All the encounters will be in one repository. I will talk about whether the all entries will be there, and the next, the following guiding principles. And positive identification of the healthcare recipient can be established through visual or referencing of the IDs. So the patients who are positively identified, data will be on the access for information system. Fourth guiding principle.
Excuse me,
privacy.
excuse me, Dr. Ajwat.
Yes.
Excuse me, Dr. Ajwat. Yeah,
yes.
I think in another 1 or 2 minutes.
Yes. I'm just, yeah. And the privacy and security, and already talk about the unique identifier, and the patients are opt-in by default. And the only authorized information system, as I explained earlier, can access this national EHR. And of course, we are not going to store all the information. The minimum data sets which have been identified, and they are in the process of upgrading, and those data will be available on the national EHR. And scalability, of course, possible. So thank you so much. Thank you for giving this opportunity. And yes, thank you so much.
We conclude these sessions because we are lacking nearly 1 hour. So there are no times for questions. Thank you so much for all the speakers.
Thank you very much for your valuable contributions. And to award the certificates of appreciation to the panelists, let me invite our chairperson, Dr. M.H.M. Ashraf first, to present the certificates of appreciation to Dr. S. Majida. Thank you, sir, and thank you, madam. And I invite Dr. Zahilan to present the certificate of appreciation to Dr. S. Dilak Kumar. Thank you very much. And to award the certificates to our chairpersons, I would like to invite Dr. J. Jayaruban, consultant surgeon at the Teaching Hospital, Badiklu. Dr. M.H.M. Ashraf. And Dr. Ahilan. Thank you very much, ladies and gentlemen, for your contributions. And let me make this opportunity for the awarding ceremony of the quiz that we conducted here. And for the certificate awarding of the medical student category, let me invite Dr. Vijay Thurukumar, consultant pediatrician at the Teaching Hospital, Badiklu. And the winner of the medical student category is Ms. NGPG Kumarihami. Thank you very much, madam. And for the intern medical officer and registrar category, I would like to invite Professor M. Umakant to award the certificates. And the winner of this category is Dr. N. Tushani. Dr. R. Tushani, I beg your pardon. Thank you very much, sir. And for the senior registrar consultant category, I would like to invite Dr. P. Mayurathan to hand over the certificates. And the winner of the category is Dr. K.T. Sundareshan. Thank you, sir. And that marks the end of the symposium. And ladies and gentlemen, there's a popular saying, as a doctor is a student until he dies, and once he considers himself not a student, the doctor inside him dies. So with that in mind, it is our time to move on to the next session that is allocated to the Postgraduate Trainees Forum. And to chair the session, I would like to invite Professor M. Umakant, consultant physician at the Teaching Hospital, Badiklu, and also Dr. Rajivan Francis, consultant cardiologist at the Teaching Hospital, Badiklu.
Before start this forum, I think better to do some maneuver. This is relevant for our forum. Please stand up for all for a few minutes, please. And take your right leg, little bit, raise it for a few seconds, right leg. Yeah. And keep on the floor. Then take your left leg, 1 minute, huh? Not a few seconds. Keep on the floor and take your hand keep it your hand like that. And do like that, 1, 2, 3, and take your right hand, take near your mouth. This is a super tea, okay? You all are prepared tea, and with the tea we start our forum, okay? Take your seat, please sit up. Take your seat, okay. Yeah, good evening. Initially, I'm confused whether it's a good night or it's a good morning, but anyway, it's a good evening. But we are 1 hour behind the schedule. Straight away, I call the first speaker. There are 3 speakers are there. This is the Postgraduate Trainees Forum. So first speaker, one of the registrar, he's a handsome, he's a good singer. I never heard about his song, but I call upon Dr. Nishant to sing a song on the proven COVID treatment protocol, the latest update. Please, Dr. Nishant, over to you.
Good evening, everybody. Good evening, chairpersons. Let's move into the topic, chronic obstructive pulmonary disease. And this is the content we are going to talk about: the pathophysiology, the symptoms and signs of COPD, the diagnosis, the treatment and prevention, the exacerbation, and the current situation, which has COPD associated with COVID-19, and the trials, the recent trials. So what is COPD? We all know it's a chronic airflow limitation basically caused by the mixture of small airway disease as well as parenchymal destruction, which is called emphysema. And it is no longer described in terms of chronic bronchitis as well as emphysema. Emphysema is a pathological term which describes the destruction of gas exchanging surface of the lung, and the chronic bronchitis, it's kind of a symptomatic term which says that when there is a cough with sputum production, which is at least present for 3 months in 2 consecutive years. And it causes major social as well as economic burden worldwide. So these are the main etiologies: smoking and pollutants. And the pathophysiology, it mainly covers the impaired lung growth, accelerated decline of the lung tissue, lung injury, as well as systemic inflammation. And the pathology has small airway disorders and abnormalities, emphysema, and the systemic effects. So the manifestation of this COPD is mainly the airflow limitation, which is persistent and which is irreversible. So the factors that influence the progression, mainly there are genetic factors, and the age and sex are the determinants, and the infection, which we get recurrent infections, and underlying asthma and the atopy history also has some kind of significance, and the socioeconomic status, especially the low socioeconomic status, which has a high likelihood of getting the COPD infection, and the chronic lung growth and the development in the preterm delivery especially, and exposure to noxious particles. So the pathology, basically it covers the chronic inflammation, where there is increased number of specific inflammatory cells in the airways, in the lung parenchyma, as well as pulmonary vasculature. And structural changes that is due to the repeated injury. So that is the main pathogenesis of the injury. And in the pathogenesis, when there is tobacco smoke, it can increase the free radicals. And these free radicals, in turn, will cause functional deficiency, and as well as neutrophil elastase increment, so that there is macrophage elastase increment and increased tissue damage. So the pathogenesis basically includes the oxidative stress, inflammatory cells and inflammatory mediators, interstitial fibrosis, and the protease, anti-protease imbalances. So oxidative stress, markers of oxidative stress are elaborated. They are mainly the hydrogen peroxide and 8-isoprostanes. So the mediators are mainly produced by the inflammatory cells like macrophages and neutrophils. So the inflammatory mediators are mainly the chemotactic factors, pro-inflammatory cytokine, and growth factors. The pathophysiology, it includes sequelae of air trapping, airflow limitation, pulmonary hypertension, gas exchange abnormalities, and mucus hypersecretion. So the pulmonary hypertension, it occurs very late in COPD, and it is due to the hypoxic vasoconstriction of the pulmonary arteries, and also there is smooth muscle hypertrophy as well. So progressive pulmonary hypertension can lead to right heart failure. So the basic symptoms are fundamentally the shortness of breath and chronic cough and sputum production. So the pointers to the diagnosis, mainly if the patient complains of dyspnea, which is progressive and persistent, and recurrent lower respiratory tract infection, and a history of smoking, and a family history of COPD or with underlying bronchial asthma. So the risk factors are mainly tobacco, occupational exposure, and indoor-outdoor pollutants. Mainly, what are the mimics of COPD? They are the asthma, bronchial asthma, lung cancer, tuberculosis, bronchiectasis, and the right heart failure, and not very much cystic fibrosis in Sri Lankan setup. And what are the extrathoracic mimics of COPD? They are chronic allergic rhinitis, postnasal drip syndrome, and mainly GORD, and the medication like AC inhibitors. So the spirometry is the most reproducible and objective measurement of airflow limitation, and which is non-invasive and readily available test. So that is done to diagnose the COPD. So the spirometry not only has a purpose or role in the diagnosis, but also follow-up as well as therapeutic decision-making. So the goal criteria says, according to the force expiratory volume, we can classify the severity from goal 1 to 3, goal 1 to 4. And also, according to the patients, in terms of patient symptom also, we have a classification, modified MRZ dyspnea scale also is there. That is according to the symptoms of the patient. And also COPD assessment tests, which we do according to the symptoms of the patient. And now the patient's symptoms, according to the severity, the patient can rate it from 0 to 5. And according to the severity, we can make a score out of 5, and altogether out of 40, so that we can calculate the COPD assessment score. And refined ABCD assessment tool, which is used to assess the severity, ABCD criteria, and A and B when there is a low-risk category, and C and D in the high-risk category. So additional investigation, we also do imaging, chest X-ray, and lung volumes and diffusing capacity test, also to kind of assess the severity. So mainly for the prevention, the smoking is the key. And for the smoking prevention, you can do nicotine replacement products, nicotine gum, and then medication like bupropion, nortriptyline. Those are the medications that are available. And the counseling with 5-step program, which is elaborated here: ask, act, and ask, advise, assess, and assist, and arrange. Now the prevention part, when we come to the prevention part, the vaccines also are very important. I think according to trial, it has a B evidence, the influenza and pneumococcal vaccines. And this is, according to the trial, the level of kind of evidence to suggest certain medication, which in A and B and C and D, A is randomized trial proven, and B is cohort study proven. And with the case report, C and D is with expert opinion. So the vaccination mainly have B evidence, as I told before. And the pulmonary rehabilitation is the core, very important, very kind of established and very important part of the treatment for COPD. Because in patients with severe resting hypoxemia, long-term oxygen therapy is a must. So the pharmacotherapy includes beta-2 agonists, anti-muscarinic agents, methylxanthine, anti-inflammatory agents, and inhaled corticosteroids. Now the bronchodilators, mainly beta-2 agonists, increase the force expiratory volume as well as change other spirometric variables as well. And beta-2 agonists, they kind of increase the cyclic AMP and thereby relaxing the airway smooth muscles. So there are anti-muscarinic agents. There are short-acting ones as well as long-acting ones. Short-acting ones, they are ipratropium and oxytropium, and the long-acting ones are tiotropium and aclidinium. So they have greater reduction in exacerbation than LABA. So remember, the LABA, long-acting muscarinic agent, have greater tendency in reduction of exacerbation than LABA, long-acting bronchial agonists. And the methylxanthine, they act as non-selective phosphodiesterase inhibitors, so their effect is really controversial in the treatment of COPD. So remember, the theophilin's effect in COPD is not well proven. And bronchodilators in stable COPD, as we already told, the long-acting muscarinic agonists have a greater effect in exacerbation reduction than long-acting bronchodilators, beta agonists, and also the combination of LABA and LAMA, long-acting muscarinic agonists and long-acting beta agonist, is more than using LABA or LAMA alone. So that is also well established. But inhaled corticosteroids are not very much established. Their role in COPD is not very much established because long-term safety data is very controversial. So mainly, remember, the inhaled corticosteroids are well responsive to the patient with high eosinophils. So with monitoring of the eosinophils, we can predict the response to the inhaled corticosteroids in the COPD patient. So remember, the combined bronchodilator therapy, which is SABA and SAMAVA, superior to either component alone. That is also a trial-proven one, and combination of LABA and LAMA is also...
Excuse me, 1 minute more.
Okay. So triple therapy is not very much available in Sri Lanka. That is also used. And the new agent, there are 2 new agents, interleukin-5 monoclonal antibody, which is mepolizumab, and as well as interleukin-5 receptor alpha antibody benralizumab, that are now used. So there are surgical treatment which is available, which is the bronchoscopic lung volume reduction surgeries, which are now available for the management. So who are the patients who need the supplemental oxygen when the hypoxemia, the partial oxygen pressure is less than 55, or the partial oxygen pressure is more than 55 and less than 60 with a kind of evidence of right heart failure. So those kind of patients need chronic oxygen supplementation. So this shows the impact of exacerbation, which has a greater economic impact as well. So this is the frequent exacerbation mortality. So when the exacerbation increase, there is increased risk of mortality. So in COVID-19 and COPD, that is also a common thing. And in that cases, IV dexamethasone 6 milligram daily for 10 days is now validated. And antibiotic use, broad spectrum antibiotic use in COVID setting is also now validated. So the trials in COPD, mainly NOT trial, shows a continuous oxygen therapy has a place. And then the Wisdom trial has stable COPD patients receiving combination therapy of LABA and LAMA has kind of good effect rather than receiving an inhaled corticosteroids. And also, we have Summit and Torch trial. They have proven that inhaled corticosteroids are not well known to be effective in the treatment of COPD. So these are the differences, and thank you.
Yeah, thank you, Dr. Sandhan, for your excellent presentation. Everything's there, very speed because of the time limit. So we move to the next lecture.
So our next speaker is Dr. K. Tilakshan. He did his undergraduate degree at the Faculty of Healthcare Sciences, Eastern University. He's going to speak to us regarding an important topic, ovarian carcinoma, the prevention and diagnosis.
Yeah, thanks for your kind introduction, and good evening to you all. So I am going to talk about this ovarian carcinoma. So this is an important disease in our daily day-to-day activity. So I want to present these two cases here. First one, this is a 65-year-old patient admitted to the surgical casualty ward with a history of assault by non-person. So she undergone a fast scan, and so there's a multilocular ovarian cyst with a free fluid. So they did a CECT, they confirmed the diagnosis of ovarian CA grade 3. So it's a third, before that, in stage in the grade 3. So this patient is had this disease for this long time, that means without known, and he admitted the history of assault. So we did a staging laparotomy, that was a grade 3 ovarian carcinoma, and the history revealed there's serious carcinoma of the ovary. So this is a real picture of the patient, and this is also that we remove the tumor from the patient. So this, and the second case, the 50-year-old patient present with abdominal distension without any complaint. She consulted GP for the treatment for obesity. And on examination, the GP found that there's a large intra-abdominal mass, and there's scan, so there's a 25 centimeter diameter mass in the abdomen, and CA125 value was near 70, and we did a laparotomy THBSO done, and histology was low-grade serous carcinoma. So this is a real picture of that patient, near 10 kilogram of lump we removed from that under guidance of my consultant. So I come to epidemiology. So ovarian cancer is one of the most common gynecologic cancer that has highest mortality rate because we are diagnosed at the late stage. So ovarian cancer is the 7th most common cancer among the women. Increase the factor, cancer lead to upward trend in the incidence of cancer around the world. Because of in 2018, 4.4% of NSAID cancer-related mortality among women due to ovarian carcinoma. So this high mortality rate due to the asymptomatic and secret growth of the tumor, because we had a large space in the abdomen, this tumor is growth, and until we diagnose in an advanced stage. So this is called as a silent killer in a gynecology. So I had one this published by Dr. Thirukumar and Island due to this recently, and they had done a retrospective study from January 12 to June 17. There's a 537 ovarian specimen. They see the histology, and 52 was malignancy. That means near 10% is malignancy. So I come to risk factor in large case control study. So multiparity and breastfeeding and late menarche and early menopause. These are the reduced risk factor for epithelial ovarian carcinoma. So multiparity, breastfeeding, and the late menarche and early menopause. So if we come to the oral contraceptive pills, so there's a 45 studies, so they done a 45 epidemiological study. So if you use 10-year use of oral contraceptive pills, you right to 33% reduction in ovarian carcinoma before age of 75. So estimated there's that COCP reduced the near 200,000 cases so far, and it will reduce 37 per year in the future if you use 10-year use of oral contraceptive pills. So, and if we come for the increasing factor, so late conception and small family size, obesity, and HRT. So these are the factors that increase the ovarian carcinoma risk. But if we come to the HRT, this is somewhat controversial. So if the woman take the hormone replacement for 5 years age, there's a one ovarian cancer risk is there for 1,000 women. But if we are start at early age of this HRT, but there's no any increase ovarian carcinoma risk. Then we come to the genetic factor. So there's a genetical predisposition to they develop ovarian carcinoma, nearly 5 to 15%. So there's a two known genetic factor, the BRCA1 and BRCA2 and MMR. There's a mutation mismatch repair gene. And we had a commercially available kit. You can check where you are is predisposed to develop ovarian carcinoma. So that kit called 23andMe. So 23 inside me. So that's 23andMe. So it's around 22,000 Sri Lankan rupees or near 80 US dollar. So they send the kit to you, and you will put your saliva and you revert back to them. So they will give what is your genetic predisposition to whether you can that BRCA1 and BRCA2 and whether MMR. So if we, for this general audience, there's a overall classification of ovarian carcinoma, endometrial carcinoma, this arises from the endometriosis, and clear carcinoma again is arises from the endometriosis, and serous mucinous carcinoma again also there's arises from the endometriosis, and low grade serous carcinoma usually arises from the fallopian tube, and mucinous carcinoma usually there's a germ cells. So if you had a clinical presentation, most of them, more than 75% of the patients are diagnosed at late stage, either stage 3 or 4. So the current 5-year survival rate for this epithelial ovarian carcinoma near 30 to 40, but if you diagnose early stage, is near 84 to 94. But no symptom present in early stage. So what are the symptoms they developed? They had abdominal distension, abnormal bubble sound, difficulty in passing urine, and they had a pleural effusion or palpable lymphadenopathy. So current guidance for the primary care provider seeing women with the symptoms suspicious of ovarian cancer recommend to go for the abdominal examination, round scan, and serum CA125 report to be, if that is abnormal, you can refer to gynecologist. So simple, small things about CA125, this is a glycoprotein, the current gold standard biomarker for the epithelial ovarian carcinoma, but it is a poor specificity. Alone can't use for screening test. So elevated only 80% of women with the established epithelial ovarian carcinoma and 50% in early cases. So we had only that early case, that CA125 rise in only the 50%. And there's another new factor also introduced, that human epididymis 4. So this also improve with the CA125 for our diagnosis. But HEA4 is a marker of the proliferation of ovarian cells. But CA125 more than 35 is considered abnormal. So we come to the precursor lesion. So actually that initially what thought was the ovarian carcinoma arises from the ovary, but now there's called a concept called T-ball hypothesis. Usually what happened, that ovarian carcinoma arises from the fallopian tube. So that cells are originated from the fallopian tube, that seeding into the ovary, and we get the ovarian carcinoma. So that called that fallopian tube that develop the serous tubal intraepithelial carcinoma. So that located the tubal junction. So that fallen into the ovary and they develop ovarian carcinoma. And the endometrioid and clear cell carcinoma, usually what happened, the tissue come from the endometrium. So they transfer to the tissue through the fallopian tube and put into enter into ovary and ultimately into the carcinoma. So this is called T-ball hypothesis. So nowadays there are so many trial to whether we can found carcinoma early. So initially there's a 3 study done, that PLC study and UK study, and the other one is a UK folk study. So all 3 studies, they are found there's no proven benefit. We screen the mother with a woman with a CA112 level with a transfer scan. So we doesn't have any screening protocol because of there's no precancerous lesion in the ovary as like other cancer. If you take a cervical carcinoma, there's a precancer lesion, but ovary doesn't have any precancer lesion.
2 minutes more.
Okay. So then we can go for the preventive measure. So if you have respect for the ovarian carcinoma, so that you are in a BRCA1 or BRCA2, what can do is you can go for the prophylactic bilateral salping oophorectomy at the completion of your childbearing or at the age of 40, whichever comes first. So other one is the tubal hypothesis. So whatever thing practicing for this LRT, so better to go for the salpingectomy. So if you done a salpingectomy, that ovarian cancer is reduced by near 64%. So those who are doing LRTs, so better to go for the salpingectomy that reduces ovarian risk, near 65%. And there are 2 other models we can tell that we risk the mother. One is a RMI, usually is a postmenopausal woman, and iota classification we can use for the premenopausal woman. And there's one of the new category of model calculator developed to assess the risk of the patient, whether it's a malignant or benign. So we get a called Adinex model. So if we give this age and whether maximum diameter, so if the scan reboot, they'll calculate automatically and give that what's the cancer risk of that tumor. Okay, so, okay, thank you. And so anyway, the cancer cell never read their relevant topic in their pathology textbooks. Thank you.
Thank you, Tilakshan.
We move to the last speaker. So I call upon Dr. B. Bhavanandan, he's one of the Eastern product. So Bhavanandan, he's going to deliver the lecture on updated management of thalassemia with the evidence of audit. Please, over to you.
Thank you. Very good evening to all of you. As I'm having few minutes and I have to rush through the presentation, and mainly I will target on the updates of management of thalassemia. Okay, this is the picture I have taken when I was doing the Saturday evening ward rounds. There are multiple thalassemia patients. They are playing each other. So as there's limited time, I will rush through the introduction part and all. And it's one of the globally most prevalent monogenic disorder, and around 70,000 cases annually. And it is particularly around, there's in world map, there's a thalassemia belt from sub-Saharan area to Middle South and Southeast Asia. And it was first described by Thomas B. Cooley almost a century ago, and one of the earliest disorder that has described up to the molecular level in 20th century. And this is the thalassemia belt. And when we look at the prevalence and worldwide prevalence, it is 1.5% having a beta thalassemia mutation in their genes. And in Sri Lanka, it is a bit higher, 2.2%. And each year, annually, in worldwide, 70,000 to 80,000 new cases. In Sri Lanka, around 80 new cases. Sri Lanka, all province has the risk, and the northwestern and the north central province are the highest risk. So as it is a disorder due to mutation in the hemoglobin chain, and you know that there is alpha and beta globin chain in the hemoglobin, adult hemoglobin, and if there's a mutation that can cause ineffective erythropoiesis, and that leads to beta thalassemia. So if the problem with the beta globin chain, that leads to beta thalassemia, and if any mutation that causes in the alpha chain, that cause alpha thalassemia. And there is another one called E beta thalassemia. So it's a point mutation in the codon 26 in the beta globin chain that also can cause similar presentation like beta thalassemia major if that is with a beta, accompanied with a beta globin mutation. So we categorize them into 2 categories, that transfusion-dependent thalassemia and the non-transfusion-dependent thalassemia. So non-transfusion-dependent thalassemia, mainly the intermediate type and mild to moderate HBE beta thalassemias, and the homozygous beta thalassemia mutation are the transfusion-dependent ones. So investigations, we do full blood count, and peripheral blood smear shows microcytes, folliculocytosis, hypochromia, and anisocytosis, and nucleated red cells as well. And diagnosis confirmed by qualitative and quantitative analysis by HPLC and electrophoresis. So what are the management? So currently we are practicing the blood transfusion, iron chelation, and the splenectomy and hematopoietic stem cell transplantation. So I'll rush through that, and we'll go to the updated management. So bone marrow transplantation. So our aim is to restore the tissue capability of producing the functional hemoglobin. So far 3,000 hematopoietic stem cell transplantation have been performed, and that shows remarkable success rates. With bone marrow and the cord blood samples have highest event-free survival, 90 and 93%. And we analyzed the pre-transplantation evaluation while using the PESARO risk assessment, and it based on 3 categories: hepatomegaly, portal fibrosis, and irregular chelation history. We categorized them into 3: class 1, class 2, and class 3. If class 1, there's no risk factors. Those people are the ideal candidates to go for the thalassemia hematopoietic stem cell transplantation. But we can do in class 3 even, but the success rate was 65 to 70%. But in the class 1, it is 85 to 90%. So there is a recent study done at China, India, and the USA, and they have compared the HLA matched relative, HLA mismatched relative, as well as HLA matched unrelated and HLA mismatched unrelated donor transplant. And that shows HLA matching is important. That shows 89 and 87% of success rate with, among others. And so the ideal candidate is young transfusion-dependent thalassemia patient with a matched sibling donor. And also before the development of the iron overload and the subsequent tissue damage. There are limitations. We still find difficult to find a suitable donor, and the patient fitness is also a problem, and procedure-related toxicity. And the future is we can transplant autologous CD34 plus stem cells, which was modified genetically, and we can transplant. That will be the future. But with the improved conditioning regimens and the prevention of graft versus host disease and more effective antibacterial and antiviral antifungal treatment cause a significant improvement in outcomes. So we have to do the pre-transplant workup with not only the serum ferritin, we have to have the ideal MRI cardiac analysis as well as the MRI liver and dry white of the liver to see the iron capacity. And also post-transplant also equally important follow-up, and with the immunization and also for the long-term follow-up up to 15 years. So the cost is high still, but when compared to the lifelong supportive therapy, that is good compared to that. So emerging therapy is gene therapy. So we'll go to the gene therapy and gene edit. So we can do gene therapy by gene addition or gene editing. So the first gene addition that performed in 2019 July in Europe, and that group is still under analysis. And there is good outcome in the pediatric cohort rather than the middle and oldest one. And for the gene addition, we can add a healthy copy of the therapeutic gene into the cells while using the viral vectors. Gene editing, we can use we can direct some enzymes to repair the genes in situ. And some more drugs are available targeting the ineffective erythropoiesis and the iron dysregulation. So we have few drugs that inhibit the JAK2 and improve the ineffective erythropoiesis. And there are some drugs that inhibit the transforming growth factor beta superfamily and cause prolongation of the RBC survival. And so with that TGF factor beta superfamily, that drug can cause clinically meaningful and maintain reduction in the serum ferritin level as well. So these are the pictures. So modulating iron metabolism. So you know that hepcidin is the molecule that inhibit the iron absorption from the gut, but in thalassemia patient, unfortunately, they have low hepcidin levels. So we are targeting that, and there are some drugs available to improve the hepcidin, blocking the binding of hepcidin. So we use many hepcidins to restrict iron absorption, and there are ferroprotein inhibitors available. And there are transmembrane protease serine 6 inhibitors, which reduce the hepatic synthesis of hepcidin. Sorry, increasing. But even though we are improving, until the level of gene therapy, we are still facing challenges with the compliance and the understanding about the illness in the parents. So we have to, our main aim of management is depend on that nowadays. But future, there will be a good thing will happen. Thank you very much.
Thank you, Dr. Bhavanandan, for your updated lecture. So now already we are behind the time, so we are not allow audience to ask the questions. So we are conclude this postgraduate trainees program and move to the last session. Thank you all the speakers. Thank you all the way and dedicated all the speakers. Thank you very much.
And for awardee certificates for the panelists, let me invite Professor M. Umakant first to award the certificates to Dr. S. Nishant. Dr. K. Tilakshan. Thank you, sir. And let me cordially invite Dr. Rajivan Francis to award the certificate to Dr. B. Bhavanandan. Thank you very much, gentlemen. And before that, let us award the certificates for the certificates of appreciation for our chairpersons. And for that, I cordially invite Dr. K. Karunakaran, consultant pediatrician at the Teaching Hospital of Batiklu. Yes. And since he is not present at the moment, I'd like to call upon Dr. Chitra Vamadevan, consultant pediatrician at the Teaching Hospital of Batiklu. First, Professor M. Umakant. Dr. Rajivan Francis. Thank you very much, sir. Thank you very much, madam.